Then we have alpha glucosidase inhibitor, good drugs widely used in our country. We have three drugs like acarbose, miglitol, and voglibose. And what do? They inhibit this enzyme. They call it alpha glucosidase inhibitor. Alpha glucosidase is the enzyme which breaks the starch or saccharides into disaccharide and monosaccharide, and monosaccharide is the one which gets absorbed in the blood. So alpha glucosidase enzyme is inhibited, then breakdown of the long chain, these glucose or starches or disaccharide will not be there, and you will have the reduction in both fasting and postprandial. Mainly postprandial plasma glucose level goes down, and you have the reduction of about 0.5 to 0.8% of A1C, and it is weight neutral, and sometimes people they lose weight also. The only problem with it can give rise because there is a delayed absorption of ingested carbohydrate. So postprandial hyperglycemia goes down. People may have bloating, flatulence, and diarrhea. So it is a dose related. It is lesser with the voglibose, more with the acarbose, but you have to use small doses and then gradually build the doses. So it could be dose related. Some people may not tolerate because of the gaseous extension of the abdomen and gases, and they say we don't like it. So we have to be careful, but these are the good drugs in the patients who eat more of carbohydrate, and quite popular in our part of this world as well as in the China. So that is important. India, China, a lot of people are using a lot of voglibose and acarbose. Miglitol used to be available. I used it, but now I don't think it is there. But it is a good drug again. Then we have the incretin mimetics. You know what is incretin? Incretins are the endogenous substances which are secreted from the gut, and they increase insulin response to orally administered glucose. So what is important? You have incretins, like they call it GIP and GLP, glucose dependent insulin release polypeptide, that is GIP, and it is produced by K cells, and glucagon like peptide GLP, which is produced by L cells. So you have in ileum and you have in jejunum. And what is important, if you give somebody the amount 50 gram of glucose by intravenous route, you see the less rise in plasma insulin level. But if the same insulin, the glucose is given orally, it produces more rise in insulin levels and lesser or the suppression of glucagon. So people started thinking that there should be something which gets secreted from the gut, which reduces glucagon and increases insulin secretion. And later on, they call it incretin. So we have incretin, and these two incretins were later on found out, GIP and GLP, and people started using them as a therapeutic agents, like GLP-1 receptor analogs, and like GLP, they work on the receptor. So people, they produce from monster gila, and then they are using as injectable. Now semaglutide is coming, which can be used as a oral therapy, and otherwise we have the injectables are available, like Victoza and Vita, or they call it a liraglutide, and semaglutide, and then we have the dulaglutide, multiple glutides available. And people realize that incretins are destroyed by a hormone, and they call it a DPP4 hormone. So why not to inhibit this DPP4 to give more rise in endogenous GIP and GLP, and this is how the DP4 inhibitors came in. So I'll be discussing more about them in coming slides. This is there. So what people use, you take mixed meal, the intestine releases GIP and GLP, and this is active compound is from 7 to, these are the peptides, or in the protein, it is also 7 to 36 active molecule in GLP. And what it does, it works on the receptors certainly, and then what is there? It gets inactivated by DP4 enzyme. So what people are using, it gets inactivated within minutes or seconds, and the people started doing DP4 inhibition. So they have inhibition. If you inhibit, you increase the endogenous GLP. And if your second thing is it works on the receptor, so people started using the GLP-1 receptor analogs. So they work on on these receptors, and they produce the same action as being produced by GLP-1 active compound, that is 7 to 36 amino acid chain. And what is there? That's what I was talking. So either you have the incretin mimetics, they call incretin mimetics, they work or they mimic the action of incretins like GLP-1 receptor analogs, or you may have DP4 inhibitor, which will inhibit this enzyme. So endogenous GLP and GIP will be there. So this is how we have DP4 inhibitor and we have the GLP-1 receptor analogs. So incretins, as I told you, they are rapidly degraded or digested by a protein's enzyme. We call it a DPP4, that is dipeptidyl peptidase 4. Dipeptidyl peptidase 4, that is DP4 enzyme, which decreases the incretin effect. So based on these, I told you already, there are two promising therapies for management of diabetes have come in. One is GLP-1 receptor analogs and other is DP4 inhibitors. So we'll be discussing in coming slides. So what are DP4 inhibitors? DP4 inhibitors are almost 4 or 5 are available. Sita, Saxa, Vilda, Lina, quite popular in our country. And then came the 10-L-gliptin, which became very, very popular. Now we have allogliptin and enagliptin, and allo is also available. Alloja and 10-L-gliptin has become popular now. After the vildagliptin is off patent, people are using more, and others are still there. Sitagliptin is the one which came first, and they have the clinical utility in trials. They have reduced A1C by around 8%. They say 0.6 to 7.75, and certainly we have this. They can safely be given in diabetic patient with the renal functions, renal failure. You may have to reduce the dosage of some, like Sita and Vilda has to be reduced, but Lina can be given in the same dose, 0.5 milligram. And they have lower risk of weight gain, lower risk of hypoglycemia, and they are cardio safe. So you can be given not the cardioprotect, cardio safe. So it can be given in any patient. They have very minor side effects like dizziness, diarrhea. Some of the patient may have pruritus also. So this, if they have problems, you may stop. Otherwise, I had a patient who had severe pruritus, and he said, "Sir, whenever I stop the sitagliptin, I'm okay." So I have stopped using, and patient is doing fine. Some of the patients, rarely you may see the side effect, but DP1 inhibitors are good drugs. They increase the endogenous insulin secretion and they decrease the glucagon secretion, and it is glucose dependent. Once the patient goes in hypo, the insulin secretion will stop, the glucagon will go up. So we have good drugs like Sita, Saxa, Vilda, Lina, and Allo and 10-L-gliptin. They are weight neutral and they have low risk of hypoglycemia or no, unless you are using them with insulin or you are using with sulfonylurea. So these are the good drugs and quite popular in our country. Then we have the GLP-1 receptor analog. These are currently like exenatide, liraglutide, lixisenatide, elbiglutide, EULA, and Tesco. So they are being used as a injectable therapy, and they given with pen-like device. This is like the chief advantages. They have lesser hypoglycemia. They are appetite suppressant, and they people lose weight. But they have problems of nausea, vomiting, headache, dizziness, and diaphoresis. Sometimes they have sweating also. Rarely people have, come out with pancreatitis. If those who have MEN, and especially in rodents, the thyroid cancer was. So those who have MEN or follicular carcinoma in family, we do not using. The GLP-1 receptor analogs, they work like GLP-1, and you are giving therapeutic doses. So they work well, and they again increase the insulin secretion. They decrease the glucose secretion, and it to be given subcutaneous. Some of them are lira like given once a day, exenatide twice a day. We have the LB and glutide, which can be given once a week also, but they have to be given as injectable. The main problem is with them is nausea, vomiting, and patient may have some dizziness, and they are quite costly. So this is how they have not become that popular, but they are quite cardio safe, cardio protective. We have two drugs which decrease the mortality and cardiovascular problems, like one GLP-1 receptor analogs. With liraglutide, we have a lot of studies and with semaglutide also. And now we have SGLT2 inhibitors, which also are cardioprotective. So this is important. So GLP-1 receptor analogs like Exena, Lira, Dula, they all to be given injectable. Some of them are long-acting, can be given even once a week, but you have to be careful because they may give rise nausea, vomiting, and the patient may not tolerate them. They have no risk of hyperglycemia, but once you give them with insulin or with sulfonylurea, hypo chances are there. This is what they are. So we are stimulate glucagon release, lowering of plasma glucose, stimulate insulin release, and it inhibits the glucagon release. So this is how they are working. And we have DP4 enzyme inhibitor, like DP4 inhibitor, I told you, and we have the increasing GLP-1 receptor analogs. So they work by increasing insulin secretion and decreasing glucagon level, and this is how they reduce the plasma glucose level, because they work with, like, glucose dependent manner. So the hypo chances are not there if you are using them alone or using with the metformin. Otherwise, you have to be careful. Gliptins, I have already talked about. Daily dose, we need to be titration based on renal function, like Elena can be given. You have to be monitoring for pancreatitis, drug side effects have to be everywhere. Sulfonylurea improve the CV outcome, UKPTS, whereas gliptins have not yet been established, but they are neutral as far as cardiovascular health is concerned. Sexa has shown some indication that hospitalization for heart failure was more, so you have to be careful. Sexa is not that popular in our country. Now people are using more and more other gliptins like Vilda or Sita or Teneli. SGLT2 inhibitors are the latest addition, and these are the good drugs. They reduce heart failure. They have been used in heart failure. They reduce cardiovascular morbidity and mortality, and they reduce weight as well as the blood pressure. So along with the glucose lowering effect. So glucose lowering effect, and beyond that you have the protection of other organs like heart protection and the renal protection. So this is how these new drugs have come in. We have so many SGLT2 inhibitors available. Mainly we have dapagliflozin and EMPA and this another empagliflozin is there, and Cana is there, and DAPA is there. They are quite popular, and now DAPA has many generic brands are available, so they have become quite cheap. Otherwise, they were very costly. Still, the original brands are available. They are a bit costlier, but they are a good one. So remember, SGLT2 inhibition. What is SGLT2? SGLT2 is a receptor which reabsorbs glucose from the proximal tubule of the kidney. So everything gets filtered in glomerulus and we reabsorb it. So if you are inhibiting those receptors or SGLT2, then reabsorption will not be there. The patient will have more of glucose will go out in the urine. So we have the glycosuria. This is how the SGLT2 inhibitors they work. They inhibit this SGLT2 receptors in proximal tubules of the kidney, and they cause glycosuria. By causing glycosuria, they cause diuresis. They reduce the plasma glucose level, and they reduce weight as well as the blood pressure. This is the multiple actions of these medications. So a member of sodium glucose co-transporter. So S is sodium, G is glucose, and we have the co-transporter. Glucose is a transporter inhibitor. So sodium glucose co-transport family, the proximal tubule and responsible glucose reabsorption. I told you almost 90% of this glucose gets reabsorbed in the proximal tubule, and this is how inhibited. The 90% will go out. So this is how they cause glycosuria. Up to 70 gram of glucose can come out in a day in a person. Inhibition of this co-transporter does the lower glycemia by decreasing renal glucose deabsorption and by promoting glycosuria. That's what I told you, although same things are here. This is the glucose filtration. This is the proximal tubule. You have the reabsorption, and you are reducing reabsorption at proximal tubule. So this is the DAPA, SGLT2 inhibition, and the glucose. So these are things. And then you have the more glucose output in the urine. So they reduce The renal threshold is around 180 to 200 in a normal person. In elderly, it goes up and it brings down to around 110. So even beyond 110, the glucose will come out in the urine and patient have glycosuria. So these drugs do not cause again hypoglycemia. They promote mild to moderate weight loss due to their glycosuric effect, and they have been shown to reduce blood pressure in patients with type 2 diabetes, and then they cause sodium loss. Or this is their approved drugs. We have three: AMPA, CANA, and dapagliflozin. The main side effects is because they cause glycosuria. Patient may have the fungal infections like urinary tract as well as that of vaginal. So one has to be careful. So genitourinary tract infection, the main side effect of these medications. Otherwise, these are the good drugs. Once we are using them, you have to be talking to the patient and giving them suggestion that you should wash your private parts once you are using these medications, either of CANA, DAPA, or empagliflozin. Now we are talking about glitazone. These are available in our country, and we have the saroglitazone. Saroglitazone is a combination of alpha and gamma, PPAR gamma agonists. And we have the PPAR gamma is the pioglitazone. Here you are having alpha also. And this class of drugs, they improve both the dysglycemia as well as hyperglycemia, and they have been shown to reduce cardiovascular risk in both type 1 and type 2 patients. And the first drug is saroglitazone. We have the lipaglyn, which is available. It helps by using oral medication and comorbidity like hepatic fat or the fatty liver or NAFLD goes down, and their triglyceride level also go down, and they work at both alpha as well as gamma receptor, and they have usually added drugs, and long-term safety data are there, and we've been used for last a decade or so. We have another class of drug I'll be finishing now soon, and we call them non-sulfonylurea secretagogue. We call them miglitazone. Though they are not sulfonylurea, but they work as sulfonylurea, and they work on the receptors in beta cells. And they action is similar to sulfonylurea, but they have short duration of action. So they are given just before the meal, and they reduce postprandial rise in hyperglycemia, and they promote insulin secretion from the pancreas. One can reduce A1C by 1%. We have two drugs like netaglinide and repaglinide are available. We have Europa and Novonorm and other medications. Hypoglycemia, weight gain are important side effects, so one has to be careful. So we have miglitazone. They are short acting, mainly postprandial rise, can be used in patient with renal failure. Insulin, I think I told you, I may not cover it, but important thing is when to start insulin. Any patient with diabetes, if they have significant hyperglycemia, if they have inadequately controlled on oral therapies, they are intolerant to oral therapies, if the lady is pregnant, if they need high doses of glucocorticoids like during this COVID time, or if they are hospitalized with acute problems like myocardial infarction, CVA, or severe acute illness, these are the time when one has to use the insulin or start insulin. And I think we are aware of multiple insulin and their duration of action. So we have the insulin which are very, very rapidly acting like Lispro, Aspart, and then we have the other medical glulysin also. We have the regular insulin like insulin R or Actrapid, which they have peak action at 3. Once you are using, one should know the duration of action and their peak of action. And then we have NPH, where peak comes around 6 to 8 hours. And then we came the long-acting insulin like glargine, the newer concentrated glargine. We have the diglutide, which are the real basal insulin. So basal insulin usually covers the nighttime hyperglycemia, reduce hepatic glucose output, and if you want to cover the mealtime, you use either short-acting or rapid-acting insulin. So most of the time in type 2 diabetes, we are using these diglutide, glargine, or the newer insulin is coming. We are using them with pen, and they work for 24 hours. So we have oral plus basal insulin we are using in our patient. So I think I should stop here. I would like to thank you as well as thank Medvarsity for connecting us here.